Welcome back to the Cyrex Labs Education Series. I am Robin Puglia. I am the VP of Clinical Education for the UK, Europe, and Ireland for Cyrex Labs, and I am a clinical consultant for Regeneris Labs, which is the UK distributor for Cyrex. In this video, I'm going to be talking about Cyrex RA20, which is the blood-brain barrier permeability screen, and also about the importance of understanding the role of the blood-brain barrier in various different clinical situations. So the blood-brain barrier is a single epithelial layer immune barrier. It is distinct from the mucosal barriers of the body in that, number one, it is not a mucosal surface, it is a vascular surface. But number two, it actually doesn't come into direct contact with the external environment in the same way our respiratory tract and our digestive tract does. The role of the blood-brain barrier is to keep the immune system and the proteins and antigens from the systemic circulation and the systemic immune system distinct and separate from the delicate tissue of the brain and the central nervous system. The first layer of the blood-brain barrier, again, which is part of the vascular system, is a layer of endothelial cells with extensive tight junctions. It is designed to restrict molecules that are greater than 400 daltons from entering the brain, and that helps to protect the brain against infections, toxins, various different immune regulatory functions in the body, and also autoantibodies and antibodies against food proteins. The proteins and the mechanism of the blood-brain barrier is very similar to some of the other immune barriers in the body, for example, the gut wall, but also the lung and the gum mucosal barriers. However, there are some very unique aspects to the blood-brain barrier that do make them distinct, and that does mean we do need to assess separately. You cannot assume that because somebody has gut permeability that they will also have blood-brain barrier permeability, and you cannot assume, and I will explain why, that if you have addressed the occludin-zonulin barrier permeability of the gut, that this will also reflect in the blood-brain barrier. So there are actually three layers to the blood-brain barrier. So when we're talking about the tight junctions, we are talking about the tight junctions of the blood vessel. And you can see here that we have that single epithelial layer and that the tight junctions are regulated by very similar proteins. It is air traffic controlled by zonulin. Upregulations of zonulin will lead to more permeability between the epithelial cells. The proteins that regulate the cells are occludins and claudins, the same way that we would see in the gut or in the lungs or in the gums. However, there are two additional layers made up of neuronal tissue to the blood-brain barrier. So as you can see here, we've got this the tight junctions and the epithelial cells of the blood vessel. Then we have the pericytes and the basement membrane. And then the third layer is made up of astrocyte foot protein. So when we are measuring blood-brain barrier permeability, we're measuring antibodies against the astrocyte foot protein. And so what we're actually measuring is immune-mediated damage to the nervous system tissue, which is the most aggressive finding of blood-brain barrier permeability. We're not just looking at blood vessel permeability, we're actually looking at damage to the neurological tissue. And so when we find antibodies to the blood-brain barrier in the systemic circulation, you're measuring damage to all three layers of the blood-brain barrier. And what we're actually talking about is measured immune-mediated damage to the nervous system tissue. We're not measuring simple permeability and looking at the occludin zonulin mediated tight junction protein permeability. So what damages the blood-brain barrier? So there is a broad range of physical and environmental influences on blood-brain barrier permeability, and some of those are expected. Infection, viral infection will create blood-brain barrier permeability as part of defense against infection and the appropriate immune response. However, repeated physical trauma, including repeated head trauma from contact sports, concussions, or traumatic brain injury, including mild concussion, mild injury to the brain that isn't associated with cognitive deficit in the moment or loss of consciousness or even a diagnosis of concussion, can set up the cascade of events that leads to prolonged blood-brain barrier permeability and neurological inflammation that might be the foundation stage for neurological autoimmunity or even cognitive dysfunction down the line. There are various different chemical and biological triggers of blood-brain barrier permeability, so systemic lipopolysaccharides. And in fact, if you have the test result combination of antibodies to LPS on an Ra2 and blood-brain barrier permeability markers on Ra20, that is a very unique, very important clinical finding that lets you know that that is a catastrophic immune event. That is a significantly prolonged inflammatory event that will have profound consequences on inflammation in the brain. Viral infections I've talked about, chemical toxicity and chemical exposure, including mold and mycotoxins, and then also chronic and acute stress. So both physical stress, including things like oxidative stress, but also psycho-emotional stress. Acute and chronic stress both create blood-brain barrier permeability and have different mechanisms through which they do that, but also different different clinical inferences because of the different roles of cortisol on NF-kappa B and on the immune system in acute versus chronic stress. Intestinal permeability can also directly lead to blood-brain barrier permeability and vice versa when you have neurological inflammation that might be driving intestinal permeability. So understanding both the gut wall, the enteric nervous system, and the blood-brain barrier is actually very important in understanding that bidirectional relationship. There is shared protein structures between the barriers. We have seen that there is the occludin-zonulin similarity. So anything that upregulates zonulin will upregulate zonulin, and the occludin-claudin protein changes in both the epithelial layer of the blood-brain barrier and the gut wall. So when you see intestinal permeability, zonulin-mediated intestinal permeability, it's very important to test the blood-brain barrier to see if what follows is the neuronal damage that you would see on Ra20. So blood-brain barrier breakdown can precede neurological symptoms by years. So RE20 actually helps us to assess both an early warning system for blood-brain barrier compromise. So understanding when we're looking at RE20 in order to be as proactive as possible and address in a preventative fashion. It also identifies patients who are at risk for neurodegenerative disease well before years before clinical onset of symptoms. So understanding when we're testing at risk, the at-risk patient population. But it also really helps us to effectively gauge our neuroprotective interventions, because blood-brain barrier permeability and the markers, especially with the astrocyte foot protein marker, changes the prognosis of the cognitive and neuroinflammatory clinical situation that we're dealing with. What do I mean by that? If you are working with somebody who is at risk for dementia, Alzheimer's, or concerned about that, and they have blood-brain barrier permeability, that person is at a much higher risk for developing cognitive deficit or neurological inflammation. And in fact, not just higher risk, they are already quite far down the pathway for the metabolic and immune changes that are likely to end in cognitive dysfunction. And similarly, with somebody with a diagnosed neurological autoimmune disease or who is already exhibiting neurocognitive changes or neuroinflammatory changes, if they also still have blood-brain barrier permeability, then the prognosis is very different. It is a much more complex situation, and it requires different clinical thinking and clinical intervention than if you have somebody with a diagnosed neurological autoimmune disease and no blood-brain barrier permeability. So we can't assume that because somebody is at risk or because somebody has a diagnosed illness that they also have blood-brain barrier permeability. Understanding if it is and or um, actually changes in an important way what we're going to do and how we're going to think in our clinical practice about this situation. So the consequence of a leaky brain is as serious as it sounds. So normal function of the blood-brain barrier helps to maintain central nervous system homeostasis. It controls nutrient transport and it excludes brain antigens from the immune system. When the blood-brain barrier is compromised, it allows environmental assaults of all kind, infection, bacterial, lipopolysaccharide, environmental toxins, food antibodies, autoantibodies to cross into the privileged area of the central nervous system, and then that allows cross-reactivity to occur. No immune tolerance to brain antigen exists. So once that breach has happened, if any of those immune proteins or immune-mediated processes are allowed into the brain, neurological damage can actually be quite rapid. This can lead to a broad range of neurocognitive inflammatory events, including immunoexcitotoxicity, neurological autoimmunity, priming of the microglia, or cognitive dysfunction. And then yeah, that's what I want to say about that, really. We also see here in this slide that the tight junctions of the blood-brain barrier really protect the brain from whatever is going on in the body. So if you have autoantibodies or food-mediated antibodies in the systemic circulation, but you have intact tight junctions of the blood-brain barrier, then the brain is protected from cross-reactivity and from the initiation of immune reactivity in the brain from what is going on in the body. But if you have disrupted tight junctions and autoantibodies in the body, or food antibodies, gliadin antibodies, dairy antibodies, casein antibodies in the body, and you have disrupted tight junctions, then those antibodies can cross into the brain and damage the astrocytes, damage the neurons, damage the myelin, and initiate new immune processes, which are much more difficult to switch off. So understanding whether or not the blood-brain barrier is intact when you find autoantibodies in the systemic circulation or food antibodies in the systemic circulation helps you understand the neurological consequences of what's going on in the body. So Cyrex RA20 measures IgA, IgG, and IgM antibodies against blood-brain barrier proteins. It helps to detect a breach before clinical symptoms appear, but it also helps you understand the consequence, the prognosis of the clinical scenario that you're dealing with in this individual case. IgM is ideal. If we are going to find antibodies, we want to get them at the IgM stage, which is the earliest onset of reactivity. IgA and IgG antibodies against the blood-brain barrier, the neuronal astrocyte foot protein, helps us understand that this is an ongoing, established immune reaction. So blood-brain barrier permeability is an important part of the pathophysiology of Alzheimer's disease, Parkinson's, multiple sclerosis, ALS, neurodegenerative diseases, as well as neurological autoimmunity. But we also need to be assessing the blood-brain barrier when there is any type of traumatic brain injury or in children and adolescents and young adults, or actually any adult who is playing any type of contact sport. And for me, this also includes horse riding and equestrian sports where anybody is falling off a horse or falling and hitting their head at any point in their childhood, teenage, or developing years. epilepsy, anybody who's having seizures, even children who have had more than one um, febrile seizure. Autism spectrum disorders, anything affecting the brain and the nervous system, and also central nervous system lupus involvement, any type of neurological autoimmune disease. There is a shared vulnerability between the blood-brain barrier and the intestinal barrier, although, as I have said, you cannot assume. These two panels work very well together, and I think that it is really important when you have established that there is a problem in one location to be assessing the other location as well. There is cross-reactivity that exists between actin, myosin, zonulin, and claudins in the blood-brain barrier and in the gut wall. So leaky gut often does lead to leaky brain and vice versa. So patients with intestinal permeability are at higher risk of blood-brain barrier permeability. Um, and so we need to understand how far down the pathway that person's immune system has taken it, especially when there is either neurological risk or neurological symptoms, including fatigue and brain fog. So RA20 and RA2 is a comprehensive barrier assessment and quite important to be running them together, often in clinical practice. So I wanted to kind of touch on the fact that there is a significant amount of cross-reactivity that can occur between food proteins and infection proteins. So again, when you have somebody that has gliadin or casein reactivity, or where you're seeing antibodies to infections in the body, it becomes quite important to run blood-brain barrier permeability to understand whether or not that what we're seeing in the body has started the process of creating neurological inflammation or neuronal damage in the brain. Higher circulating antibodies to foods, and some of these foods in particular, gluten and dairy, but also higher circulating antibodies to infection, has a much greater brain damage potential. And once that blood-brain barrier is breached, the antibodies flood the nervous system tissue and can set up very quickly a significant amount of inflammation and damage that might not be obvious in the moment, but are the cascade that begins an event that can end years or even decades later in significant neurological damage. So the earlier we can identify, the more proactive we can be. And the stakes are high with the brain. So it is important to be able to intervene as early as possible and to be as aggressive as we can with protecting the brain and protecting that delicate neuronal tissue. So leaky gut, leaky brain is a bidirectional pathway. When you see something in one area, it's really important to assess the other area as well. So there are also some emerging clinical connections with long COVID and neurological symptoms and blood-brain barrier permeability. So we have known since very early on in the pandemic that a lot of the presentations of COVID infection were neurological, that this is a neurological virus, that it does have the ability in some people to directly to cross the blood-brain barrier itself to set up infection in nervous system tissue, as well as to drive a significant amount of neurological inflammation, even in non-neurological presentations of COVID itself. In long COVID, some of the most profound, most prevalent symptoms and symptom presentations include memory impairment, concentration issues, persistent fatigue, mood changes, sleep disturbances, right? And really, it's a very strong neurological presentation with COVID and long COVID especially. So SARS-CoV-2 may directly damage the blood-brain barrier through the ACE2 receptor. There is a lot of viral-induced inflammation of the brain and disruption of the barrier integrity of the blood-brain barrier. There can be a lot of molecular mimicry between the viral proteins and neurological tissue. And when there is also persistent immune activation, that this maintains blood-brain barrier permeability. So quite important to be running RA20 alongside, well, in anybody that has active COVID infection, recurrent COVID infection, or long COVID. But I would also extend that out, to be honest, to anybody that has post-viral fatigue of any kind, including people who have just been diagnosed with chronic fatigue syndrome or ME. And this helps us to guide interventions that will help to support the neurological tissue more specifically. Um, Again, a lot of conversation around mold and biotoxin mediated illness and the role of biotoxins in chronic fatigue and autoimmune disease and complex chronic illness. But part of the way that mold and biotoxins mediate fatigue and immune system dysregulation and systemic organ dysfunction is through neurological inflammation and blood-brain barrier dysfunction. So mycotoxins from mold exposure can directly compromise the blood-brain barrier. This allows lipopolysaccharides that are also often present in biotoxin-mediated illness to upregulate a severe amount of inflammation in the brain and the nervous system tissue. Lipopolysaccharides can also enhance blood-brain barrier permeability. So we create this vicious cycle from biotoxin mediated exposure to direct damage of the blood-brain barrier and inflammation of the nervous system tissue. Chronic inflammatory responses damage tight junctions and also allows for accumulation of toxins directly in the brain tissue. So some of the clinical presentations that we expect to see in biotoxin-mediated illness include chronic fatigue, which we know has a significant neurological and neuroinflammatory backbone to it, cognitive impairment and memory issues, mood disorders and anxiety, and multiple chemical sensitivity. So, alongside identifying, the biotoxin and immune consequences of mold exposure and, endotoxin and bacterial exposure from water damaged buildings, we also need to look more closely at not just neurological autoimmunity and neuro autoantibodies, but also looking at the blood-brain barrier permeability. We can also look at especially if somebody is co-presenting with multiple chemical sensitivity, RA20 alongside RA7, looking at neuro autoantibodies is RA11, which is the chemical immune reactivity panel. So we also know that there is a strong relationship between chronic infections and hidden infections and blood-brain barrier permeability. So some of the biggest culprits for creating blood-brain barrier permeability from infection include Borrelia and the tick-borne illness family, Epstein-Barr virus, cytomegalovirus, Coxsackie virus, and the chlamydia family, so including chlamydia pneumoniae. So which can be found in the gut, but also in the nasorespiratory tract. There are multiple different mechanisms through which the different types of infection can create barrier permeability of the blood-brain barrier, but also persistently maintain barrier dysfunction over time. So when we're dealing with Epstein-Barr reactivation, especially when there's fatigue, and neurological symptoms associated, or when we're picking up on, Lyme and tick-borne illness, nasorespiratory repeated infections, it's also quite important to be running blood-brain barrier permeability to see how directly the infection is driving neurological dysregulation. Because remember, if there is also blood-brain barrier permeability, it changes the prognosis and it needs to change your clinical thinking about how to support the nervous system, specifically in this fatigue or in this infection or in this immunomodulation strategy. So mitochondrial function and neurological function are very tightly entwined together. So your brain makes up about 2% of your body weight, but it uses somewhere between 22 and 25% of your ATP output during the day. Mitochondrial dysfunction and neurological inflammation are hand in glove with each other. Inflammation of the brain can directly drive mitochondrial dysfunction. But when we have mitochondrial dysfunction, that can also significantly contribute to neurological inflammation and blood-brain barrier dysfunction. So microglial activation, so the immune activation in the brain, the immune cascade, the activated immune cascade in the brain, can directly drive uh, damage to the mitochondrial membrane and also to mitochondrial function and output in the neurological tissue itself. But once you have that established mitochondrial dysfunction, then this massively reduces ATP output, which is a contributing factor to chronic fatigue, but also to neuromuscular presentations of fatigue. And this then, especially when there's neurological inflammation that is driving the mitochondrial dysfunction, creates a self-perpetuating cycle of dysfunction. So understanding where to intervene, because if you are just supporting energy production and supporting the mitochondria, if you've identified that there's mitochondrial dysfunction, but you haven't identified the neurological inflammation aspect that is driving the mitochondrial dysfunction, then you are going to end up only getting halfway down the road of repair for this person. So some of the clinical manifestations of neurological driven mitochondrial dysfunction include severe and persistent exhaustion, which is all of your post-viral fatigue, chronic fatigue, ME cases, post-exertional malaise, especially when it isn't supported by graded um, energy budgeting. Sleep disorders and mood changes. So sleep disorders can include the need for more than 12 hours of sleep a night or persistent um, inadequate amounts of sleep, non-refreshing sleep, insomnia, or waking multiple times during the night. So blood-brain barrier repair is essential for chronic fatigue recovery, but it is also essential for um, for being able to appropriately address the neurological inflammation that is driving mitochondrial dysfunction. So understanding when that is one of the jigsaw puzzle pieces of a chronic fatigue case or of mitochondrial dysfunction, especially when there is also biotoxin-mediated illness or infection-mediated inflammation, helps you to create the most accurate, most effective clinical strategies. We want to test, don't guess. You don't need to treat the blood-brain barrier if there is not blood-brain barrier dysfunction there. But if there is, it can really change the landscape of what you do in clinical practice and the efficacy of what you're doing in clinical practice. So who should be tested? All of the people that I've just talked about, obviously. So anybody playing contact sports, patients with chronic intestinal permeability or where you have evidence of intestinal permeability on a stool test or on RA2, family history of neurodegenerative disease or family history of neurological autoimmune disease, chemical exposure history, so nail technicians, beauty therapists, firemen, people who work with glue as part of their work. Any cognitive changes or brain fog, unexplained neurological symptoms, post-concussion syndrome at any point, immediately post-concussion or years post-concussion, early signs of memory impairment, and any unexplained or persistent fatigue, but very especially biotoxin-mediated, tick-borne, infection-mediated. So here we have a clinical interpretation guide, although this also exists on the Cyrex portal. Obviously, we're not looking at clinically significant blood-brain barrier breakdown if there are no antibodies, IgM or IgG, IgA mediated. If we have positive IgA and IgG, then we have established ongoing chronic blood-brain barrier breakdown and damage. If we have IgM, then this is early onset blood-brain barrier permeability. If we have both IgM and IgG and IgA, then this is active and progressive. It's established and it's ongoing. This is obviously the most serious of the findings, and it requires kind of urgent prioritization. So treatment implications. So when the blood-brain barrier compromise is detected, we want to be then really assessing the environmental triggers to understand if there is an ongoing infection, an ongoing toxic exposure, or if we have an established injury that is continuing to drive blood-brain barrier dysfunction, neurological injury. We're looking to support blood-brain barrier repair, but we also need to really make sure that we're implementing appropriate, effective neuroprotective protocols and dampening down and supporting the immune system of the brain in a targeted fashion. You cannot assume that what works for the immune system of the body is also going to be effective in the immune system of the brain. And you need to be really paying close attention to monitoring treatment responses because the stakes are very high when we're talking about the brain. So a comprehensive neurological assessment would include RA7, where we're looking at neurological autoantibodies, RA2, where we're looking at the intestinal permeability markers, including lipopolysaccharide antibodies in the systemic circulation. Remember, the combination of lipopolysaccharide antibodies and blood-brain barrier permeability is the most severe, serious finding in terms of consequences of the brain. However, I would also say if you also have neurological autoantibodies or infection antibodies, that is a very significant neurological finding. So we're also looking at chemical immune reactivity because that has such a significant impact on blood-brain barrier permeability, and we're looking at pathogens to understand if there is infection driving not just blood-brain barrier permeability, but also neurocognitive and neuroinflammatory changes in the brain. We can use RA20 to retest at about 3 monthly intervals in order to track treatment response. And we could also consider genetic testing to understand more about the susceptibility for that individual. Okay, so that is a little bit more on RA20, blood-brain barrier permeability screen, and the reason that it's a very important clinical tool for infection, neurocognitive disorders, neuroinflammatory disorders, injury, biotoxin illness. I would also say PANS, PANDAS, and although that falls under neurological autoimmunity and biotoxin mediated illness. Thank you so much for your time.